Okay, please join us here.
Thank you very much, Dr. Azad. I want to make a bit of a confession about this talk. It's kind of taken on a life of its own. And about a year ago, I was asked by the organizers of a conference on women's mental health to give this talk. They gave me the title, and I kind of protested a bit that this wasn't really what I do, but you know how it goes. Oh, you'll be great, it'll be fine. And then the Royal Ottawa has a series of public conversations, and that group said, oh, that went so well, would you give it again to conversations at the Royal? And then I thought it was all over, and then Marion called and said, well, that went so well, we heard it was great, will you give it again? And I was joking with Kelly this morning, there is not a talk that I've done less research for that I've been asked to give more, so that might be a message about my style. So we're always asked to give a disclosure slide about our industry ties, and I have none. Probably the last gift, if you like, or meal that I accepted from industry was for our geriatric psychiatry rounds up until a year ago. We were sponsored by multiple industry reps to provide lunch for an educational initiative, and they had no content advice to give. But I have another disclosure slide. And as I've said, that's not really my thing, because I do treat aging men as well. And so if I stray from the stated topic and stop talking about just women and just talk about people, I hope you'll forgive me, because the principles that I'm going to talk about would cover everybody. And disclosure slide number 3, that does make me a bit of an authority. I am an aging woman, so I feel that gives me a little bit of credibility. And I know with the regional geriatric program, I am preaching to the choir today. So some of the statements that I'll make or ideas that I'm going to run are obvious to everybody who's here and obvious to everybody who's going to be joining us from an outside site. Our objectives, my objectives, are going to be to discuss what happens to women who have an early onset diagnosis, a mental illness early in life, and then stay alive and age. What are the issues that we need to be aware of? I want to touch on stigma in mental illness for older women, and again, the principles would apply as well to men and to younger women. And then to review late life mental illness for those who develop problems after the age of 65. We'll cover a little bit of the demographics of aging, and as I said, with this audience, I know that you already know there's a tidal wave of aging coming. We'll talk about changes in normal aging, because they're very important when we think about what happens over the lifespan to people who are taking very potent medications and perhaps developing complex medical problems. I've mentioned that we'll talk about stigma and then late onset mental illness, and then very briefly at the end, talk about treatment and recovery. So we know that for years we've been saying the baby boomers are coming, but they're here. Those born in 1947 turned 65 this year. I happen to be at the crest, at the peak of the baby boomers, so all of the young people here and perhaps joining us, please learn all that you can so that you can look after us when we come to you for help. Right now, 13% of the Canadian population is over 65, and by 2041, it's thought that will double to be almost a quarter of the Canadian population. And good luck with that. Right now, it's estimated there are 147 women for every 100 men over 65, and that will probably become even more unbalanced as we go forward. Most older men are married, and I bring up that point, like even the latest census data show us that those over 85 years old, men, almost half of them are still married. And I make that point because it means that many of them will have a familiar caregiver when they become ill or frail or develop illnesses. But for women, most are widowed or single, So over 85, 90% of women do not have a partner. So what happens to us with normal aging? And my two little ladies here are saying, I don't think of my skin as saggy, I think of it as relaxed fit. So despite all our best efforts, if we're leading a healthy life and doing all the right things, we will still have things that happen to us that will impact on our future physical health and will impact on our mental health and the treatment of both. We know that with normal aging, there are physiologic changes in the cardiovascular system. So there is a slight increase in blood pressure. Baroreceptors that help us maintain our blood pressure may become more sensitive and react more aggressively. And this will have impacts on the side effects of medication. We know there are endocrine changes that are normal with aging. And the most simple one I can think of is menopause, which for many people heralds a change in their emotional well-being. There are respiratory changes, so the lungs become perhaps less able to clear debris. And if someone were to develop depression, that might be extremely important if they were to become less active or take to their bed in the development of pneumonia. And there are gastrointestinal changes that might impact on the absorption of vitamins that are necessary for mental and physical health, or in the way that medications are absorbed and distributed within the body. There are pharmacokinetic changes with normal aging, and pharmacokinetics is what the body does to medication. These areas of absorption, distribution, protein binding, metabolism, and clearance through the kidneys are important at any age, but particularly as we age, there are changes in how drugs are distributed through the body. So somebody taking a fat-soluble drug early in life is going to have a particular distribution in the bloodstream and stored in the fats in their body. But as we age, there's sort of a flip, and we have more fat cells and a reduction in the blood volume, so the amount of drug available to be active changes. There are some... let me just go back for 1 second. There are also going to be changes in metabolism. There are changes in the blood flow through the liver, where many, many medications are metabolized. And once again, it can go in both directions, that we metabolize drugs slower, so more is remaining in the body to have an effect, both good and bad. We'll also note that some of the drugs that are metabolized through the liver, even at a younger age, have to be monitored very carefully, and there are blood levels that can be measured. Renal clearance as we age can decrease, and so for drugs like lithium, which are often used as mood stabilizers in patients with mental health challenges, can become a real issue, and I will get to that a little bit later when we talk about the changes that happen late in life. There are brain changes with normal aging, sadly. It's estimated that perhaps up to 1% of neurons are lost each year after the age of 60. And depending on where the neuronal loss may be, we may see subtle changes that are still considered normal in executive functioning, in memory, in sleep, in gait and posture, and in smell and taste. So these changes can happen and be considered normal if they're subtle. Obviously, if they move beyond that subtle stage, is when Dr. Azad and I start to see people who have changes that are either alarming to them or alarming to family members or physicians who are caring for them. There's also an increased susceptibility in the blood-brain barrier. We are all sort of able to, in a way, keep drugs out of the brain that are not supposed to be there through a very potent barrier. But this changes as we age and becomes a little more leaky. That becomes extremely important as we talk about medications that are used for mental health issues. There are changes in the imaging of the brain that are still considered normal, and most importantly, I get reports of shrinkage of the brain or atrophy that the radiologist tells me are normal for age. And that's probably one area that I think we're going to see change over time as the radiologists become more in tune with some of the atrophy that or shrinkage that they're reporting as normal probably is not, doesn't match what we see clinically. Other changes that are considered normal that can affect people as they age, for women in particular, a decline in mineralization of bone that can lead to fractures if one falls. And that becomes important again if we're going to use treatments that are going to affect balance or are going to lower blood pressure and make that person susceptible to falls. Impaired postural reflexes, increased sway, and poor balance in subtle ways are still considered within normal limits. But again, if we start to exaggerate them, we're putting people at risk for falls. And it doesn't have to be medication that's prescribed. Again, preaching to the choir, you all know how many of our patients self-medicate from the Friendly Shoppers Pharmacy with over-the-counter medication for their nerves, and this can also have a very devastating effect on whether they can stay upright and keep them from falling. And hearing loss, which again is considered normal in more than half of people over 70, can make people appear to have cognitive impairment when they actually do not, because they're not catching what's going on in conversations. So I'm going to switch now and talk about early onset mental illness for women as they age. And I hope you'll keep in mind all that I've talked about that's supposedly normal for aging and how it might affect women who are already suffering from mental illness. So if you have a mental illness of early onset and you live to grow old, these normal changes will affect your treatment with the psychiatric medication, and it will affect the expression of side effects of that treatment. Aging itself will make you vulnerable to develop mental illnesses particular to old age, and the most obvious one, I think, would be dementia. Living long enough is the major risk factor that puts you in the arena of developing that illness. Aging itself makes you vulnerable to develop physical illnesses, many of which will then, in a cascade, affect your mental illness, particularly if they affect your function. And aging itself, and we'll talk about this in greater detail, will bring with it psychosocial issues that can affect your access to care and services. I'm going to talk a little bit about stigma and what I call the triple whammy for stigma. So this is not particular to aging, but if you have a diagnosis of a mental illness at any age, you are already stigmatized in our system, in our society. The Canadian Psychiatric Association, their latest journal, the September issue, was devoted to stigma, and I was very saddened to see that from consumers, so patients who have been diagnosed with mental illness, one of the major areas that they identify as being most harmful to them is the stigma they suffer from medical professionals, including mental health professionals. And it is a very touching way in which they describe how all of us here contribute to the stigma and how they feel about having the diagnosis of mental illness. And that includes all ages. The next part of the triple whammy, you are old. So assumptions are made that you must be frail and you must be confused. And so that's completely written off as you arrive. Not with this group, I hope, but with those who are not devoted to aging. That if you are old, then you must be confused. And then the third part of the triple whammy is you are female. And there are assumptions made about whether you complain a lot, you express yourself emotionally, and so can be dismissed for some of your suffering. All three of these will affect your ability to obtain accurate diagnoses, effective treatment, and to access services. I wish it weren't so, for both physical and mental illnesses. And then one of my residents, one of the times I've given this, pointed out to me that there is a quadruple part to this stigma. And if you're a member of a visible minority, that can also add to the reception that you might get in trying to obtain a diagnosis and services. So mental disorders commonly diagnosed earlier in life would include major depression, anxiety disorders, bipolar disorder, schizophrenia, substance use disorders. These can actually be diagnosed in people in their teen years, but most typically surface for people in their early 20s, and then for many can become part of their life as they continue to grow older. So what should we keep in mind if we have in our practice or in our clinics people who come with an early onset mental illness and who are now growing older? You would have to expect, if you know about the normal effects of aging, that you will have to lower the doses of some of the psychiatric medications to obtain the same treatment effect and to reduce side effects. We talked about metabolism being affected, about the brain having changed, where many of these medications have an effect. And I've given some examples here. I gave you the one about lithium. There are, in fact, actually well-reproduced lower ranges for the blood levels of lithium. However, in Ontario, unfortunately, we have not been able to have that translated onto the laboratory reporting sheets that come from the labs in Ontario. So I've had the misfortune to have people, women particularly in my practice, die from medical professionals not understanding that those levels that are appropriate for young adults are toxic for older adults. And the cascade of problems that happens after that is really unfortunate. Antipsychotic medications used for psychotic disorders and for many, many more things as time goes by can have people appear to have Parkinson's disease through the side effects of those medications, and other movement disorders can develop. Unfortunately, if the physician or treatment team isn't tuned into this problem, I've seen that cascade be that somebody's actually diagnosed with Parkinson's disease and treated for Parkinson's disease with all the problems that those medications can bring, without the simple technique of perhaps wondering if a little less of the medication might be as effective for treatment and might lower these side effects in some way. Anticholinergic medication was traditionally given to young adults diagnosed with schizophrenia who were put on antipsychotic medication. And they were given in the same prescription and at the same time. It seems kind of crazy now, but it was some theory that in case they were to develop those problems like Parkinson's disease, these medications would protect. And there's some theoretical considerations there. However, even those who never developed these side effects stayed on these anticholinergic medications for decades. And I'm still meeting people who are coming to my practice now who are still on these medications. This doesn't really serve them well in terms of memory and function, to be on high doses of medications that block acetylcholine. Some even arrive having been diagnosed with dementia and placed on cholinesterase inhibitors, so now they're on medications that actually have the opposite effect at pretty healthy doses and all the side effects that come with that. We know recently antidepressants that we have used in both young and old are now we are getting warnings from Health Canada about problems that may develop from a cardiac standpoint, and we're being advised to lower doses of antidepressants, particularly in the SSRI category. So that's just 4 examples, but I can give you many. So considering whether or not this young person who's aging may get by with a change in medication is really important. What else should we consider if we have women in our practice who have aged with mental illness? Well, the psychiatric medications, as we're discovering, can cause medical problems or worsen medical problems. And again, I've given you some examples here, but the most harmful, one of the most harmful, are the metabolic syndromes that can develop with the use of antipsychotic medication. So we know that massive weight gain can develop if strategies are not put in place for these individuals. And then the cascade of diabetes, increased cholesterol, and all of the problems that develop when vascular risk factors have kind of gone a little bit crazy. We know that lithium, with years of use, can have the person develop hypothyroidism. We've talked about Parkinsonism with antipsychotics. They also can be culprits in postural hypotension. And that leads back to that loop I talked about with falls and fractures. So I'm not going to read every single thing, but only to say these medications that individuals that you will meet may have been on for years may have caused medical problems, and rather than simply treat those problems as they arise, which you must do, considering that perhaps altering the doses or getting assistance from geriatric psychiatry to perhaps try other medications or lower doses might be the way to go. And as always, and again, I don't need to say it to this audience, new onset of confusion is never normal. It might be common, you might know why, but if you don't know why, it is not normal aging. And individuals who grow old with or without mental illnesses are at risk for developing dementia because they're alive, and that's just the way it is. And they're also at increased risk, I would say, more than people without mental illness for developing delirium from both the medications that they're on and the treatment of medical problems that develop over time. So I know I'm giving you quite a mission to go out, and I'm going to add a warning. When I started in psychiatry, I was so appalled at perhaps the way I was thinking more mistreated people in my practice who had grown old with mental illness, because I was kind of afraid of the drugs and I didn't want to rock the boat. I sort of went on a mission to change everybody's medications, and anybody who knows me knows I'm a bit enthusiastic about most things I take on. I made a lot of people very sick by doing it too fast, all with the right intentions. So even though I give you this mission, it has to be kind of approached logically, and it has to be done with some thought and maybe with some help from other teams. Frequent problems and common stresses of aging for all women certainly affect those with mental illness and those without. So dealing with death and loss, retirement from work and other active roles, housing and relocation, whether it's planned or unplanned, financial changes and challenges, even as simple for our population of people who are aging with mental illness, the switch when they turn 65 from no longer having ODSP benefits and having to switch over to benefits that come simply from turning 65, which are not quite as generous. Medical illnesses, physical disability and functional decline, changes in family relationships, the caregiver role, whether they want it or not. And then for those with mental illness who have grown older, poverty is certainly a part of the picture that we see. Social isolation. Again, you don't have to have had a mental illness through your life to have social isolation, but this population in particular becomes socially isolated. A lack of transportation. We come up with some pretty great plans in our day hospital to keep people well, and sometimes the lack of money to pay for transportation becomes the barrier to this person staying well. This is a whole talk in itself, and I promise not to go on, but exclusion from criteria for home care services, I think, is a crime. And we battle this. I'm looking at my partner in crime up there in the audience, Carmelina. We battle this on a regular basis. I think it is unconscionable that if you have a mental illness, the people tasked with providing home care services can throw their hands up and say, mental illness is not our mandate, when we're saying, but what about the arthritis, the falls, the diabetes, the insulin? She can't see the syringes. What about all of those things? Mental illness is not our mandate. Okay, I won't say any more about that. Multiple medications with complex instructions. And I would say that those of us who have not yet reached old age struggle if we are even given a prescription for one medication like an antibiotic to finish it and take it appropriately. At least I do, and I don't think I'm demented yet. I just forget. I don't remember that as soon as I feel better, I mean to take it, but I don't. So imagine if you had 6, 8, or 10 medications with complex instructions, some of which you've taken for years, but the good doctor's trying to change, and new ones to treat your medical problems. And people with mental illness are triaged with a different lens, and we talked about that with the stigma, in the emergency room and in primary care settings. And I take call at the general site, but I think this could be true of an emergency department anywhere in an academic setting. Patients who have a history of mental illness, who arrive with confusion, are triaged, not every time, but many times, directly to the psychiatric people, even when it turns out that they are arriving with an acute and fluctuating change in their cognition, and in fact they have a delirium and medical reasons why they're arriving the way they are. I'm going to talk briefly about that caregiver role, because we can't talk about women and aging without talking about the caregiver role. Our healthcare system depends on unpaid caregivers. It's just a fact of life. It turns out most caregivers of elderly disabled individuals are women. Not exclusively, but most elderly people are women, and they end up being the caregivers. Many are themselves elderly. And they become kind of an intermediate category of those who get mental illness early and those who are diagnosed late. And we believe this caregiver role, if you're caring for an elderly individual with mental and or physical disabilities, you are twice as likely to develop the mental illness of depression. It's not too surprising, but something to keep on the radar all the time when we are caring for that elderly, frail individual needing care, that we also need to keep our eyes on their caregiver, who may have been robustly well when we first become involved in the case, but we certainly in our day hospitals see them deteriorate mentally and physically as the caregiving role goes on. Different talk about the 3,500 people waiting for long-term care and all of the challenges that we face in trying to provide care to frail elderly, but keeping in mind that mostly it's elderly women who are providing that care in their homes. And this cartoon, I know what you're going through, dear. I buried my husband last year, but they found him in time. Just an illustration of how frustrating and worn out caregivers can get. I love that cartoon. It's not very polite, but I love it. So now I'll talk a little bit about late onset mental disorders. And if I mean, certainly anyone has a question, they can interrupt, but I've tried to leave lots of room to talk, to answer questions after. So mental disorders commonly diagnosed earlier in life can also be diagnosed for the first time in individuals over the age of 65, and then we just call them late onset or late life disorders. So depression, which I had on the list of early onset mental illnesses, it's thought that up to 15% of community dwelling elderly have significant depressive symptoms, and then those rates go up exponentially for individuals. If you looked at individuals who are in a primary care setting waiting room, they're higher in hospitals, they're very high in long-term care facilities. And being female appears to be a major risk factor for developing depression. Bipolar disorder, for late onset diagnosis, there doesn't seem to be a gender difference, and males are equal to females. In schizophrenia, which we all think of as a young person's disease, at least when they are diagnosed, actually 3% are diagnosed after someone's 70 years old, and mostly it is women. And substance use disorders. This one's a hard to get a bead on. A couple of the studies I looked at said about 1.5% could be diagnosed with alcohol abuse. And they talked about a category that was pretty high of problem drinking. And I believe this is the person who, through their life, had the cocktail at 5 and the glass of wine with dinner and then maybe a brandy after dinner. They were able to handle that young in life. That's carried on, although in my experience, that cocktail may now be at 3 instead of 5. But anyway, but their brain and the body changes I spoke of means they can no longer manage. Even if the amount they drink has not increased, they can no longer handle that amount of alcohol. And I think that's the category they're talking about with problem drinking. So again, with this audience, I don't need to tell you that the 3 Ds that geriatric psychiatry are most focused on are dementia, delirium, and depression. And I don't need to define dementia for this group, but just to remind you that it's a condition of acquired cognitive deficits sufficient to interfere with functioning. Delirium, an acute, potentially reversible condition characterized by fluctuating attention and consciousness. And depression, an alteration in the usual mood with lack of enjoyment or sadness, and many vegetative features that interfere with eating, sleeping, concentrating. Common psychiatric disorders in those over 65, certainly dementia, and as I said, aging is the major risk factor for developing that. And 30% of those over 85 are affected by dementia. For delirium, it's thought that about 1/3 of general inpatients in medicine and rehab have a delirium at any time that they're in the hospital. And then when we move to neurology or post-surgical units like orthopedics, the numbers go up dramatically. I don't think we have a clear understanding of the interplay between the condition that brings people in for surgery, the anesthetic, the medications used post-operatively, the environment that they're in, and it's likely an interplay of all of those things to a lesser or greater extent. Psychiatric disorders in the elderly don't come in neat packages. I guess they don't in younger adults either. But dementia is often complicated by delirium, depression, and what we call BPSD, so anxiety and psychotic symptoms that can enter the picture and can be misdiagnosed as being separate psychiatric disorders. Late onset depression, so that's for people who've never had a depression in their life until after the age of 65. We know that's associated with a very high risk of developing dementia in the next year or two, or at least being able to be diagnosed. And we know that anxiety symptoms are very common in early dementia. They're very common in depression, very common in substance use withdrawal. And so a very careful look at all categories needs to take place when people develop new conditions that are thought to be in the psychiatric realm. We can't just stick a label on and not look at all of the other coexisting conditions that might be responsible for their presentation. Medical problems, well, that's this gang's main practice, often co-occur in the elderly with mental illness. So medical problems can mimic psychiatric illness. So a person with Parkinson's disease can have visual hallucinations either as a part of the disease or a consequence of the treatment. Medical problems can cause or precipitate psychiatric illnesses, so strokes, thyroid disease, or can cause anxiety or depressive symptoms. Medication for the medical problems can interact with the psychiatric drugs that the person may be on or the drugs that you may place them on for those psychiatric symptoms. They can also cause depression and delirium. So we have people being placed on benzodiazepines at any age, sadly, for anxiety, but these drugs are depressants, and they certainly cause memory problems and confusion in the elderly. And if someone prescribing them is not aware of that, they can start to treat the side effects of the benzodiazepine with other medications, and then you can imagine the mess that ensues. It's mostly what we do in day hospital. Try to extricate people from the 18 or 20 medications that they might be on before we can decide whether or not they actually do have psychiatric problems that are primary, or whether the entire situation has been drug-drug interactions. And psychiatric drugs, as I mentioned, can worsen medical problems: blood pressure, weight gain, blood sugars, falls and fractures, confusion, visual problems, so that always has to be kept in the lens. I've mentioned to you that dementia is common, so over 30% in those over 80 or 85. I put this slide up, and it's probably hard for people to read who are not here and just have it on their handouts, but just to tiptoe through the right side of that slide, the behavioral flags for healthcare professionals. Again, I don't think this group would need any reminders, but sometimes when we're caught up in our busy day and there are patients for whom we are treating medical problems and they happen to be bothering the staff with frequent phone calls, or they're just not complying with their medication instructions, or there's a change in appearance, they're missing appointments or showing up on the wrong day, it's pretty important to keep that dementia piece in mind, because we can sometimes, especially when I've had patients for years, I kind of get to know them so well that I might let my guard down and not be thinking about what the meaning of these symptoms might be. So just important to keep in mind. I'm going to touch on driving because I think that's hugely important, and I draw your attention to the date not too far into the future of 2028, when the blue bar is those over 65 who will be estimated to be driving with dementia, so almost 100,000. This is Ontario Ministry of Transportation data. And almost 60,000 of those over 80 who will be driving, they've extrapolated from the percentages of people who will have dementia. There's a lot of people on the road driving with dementia who've not been diagnosed. Some have, but some have not. And I think it's going to be a huge problem. So do you just try to take my license away when I develop dementia? I will fight you like all of my patients fight us. And I think we are probably going to need better strategies for how we extricate people from their cars if we're going to have so many people with this diagnosis of dementia. What about delirium? We've mentioned what the definition is. Why don't we recognize it in hospitals? One of the reasons why I think there's a low rate of recognition is hospitals are organized in that acute care model of one thing wrong at once, so one thing wrong at a time. That's certainly not true, I know, in the geriatric assessment unit, but in other units on the floor that I know you guys are asked to go and see patients on, and delirious patients are never as simple as one thing at a time. Patients are often unable to give a history, so they're called poor historians. I've mentioned that assumptions are made about their usual level of functioning, so people might consider there's no need to look into it. And I think very important is frequent falls are not recognized as a marker of trouble, and assumptions are made that this person must fall all the time. Why should we be worried about recognizing and diagnosing delirium? Well, we know they have a prolonged length of stay in hospital. It's estimated up to double. They have worse functional outcomes, so go on to that list for long-term care that is so long in the Ottawa area if it's not recognized and turned around at a fast pace. We know they have higher rates of long-term care placement. We know there's the risk of permanent cognitive decline. And I think we used to believe and tell people not that long ago that delirium was totally reversible, and we would tell families this will all turn around. We know that's not true, and I don't want to imply that because we're not diagnosing it early, that's the reason. I think sometimes the delirium is kind of the last final step before the diagnosis of dementia. And we know that people with delirium die. There are worse rehab outcomes because these people cannot understand the instructions that they're getting on rehabilitation wards. And we know that delayed recognition will lead to worse outcomes. Late life depression, I've mentioned what the symptoms would involve, and you're all familiar with them. It's very common, but often undiagnosed, again, because of beliefs about what's normal with aging. It is a very costly condition. It's debilitating. People die from the depression. And it's expected that the cohort of baby boomers who are now entering the aged group will have higher rates than the current elderly cohort. There's something about the current cohort of elderly, whether they are more stoic, whether it's because many of them lived in the post-depression era. We don't understand why the rates for that particular group are so low for depression, but they are. I don't think that's going to be true for my gang. I think for the young people here, you're going to have to be treating a lot of people with depression. We've been much more vocal about our emotional needs, and I think we have a much better language for expressing when we are emotionally distressed. I think it's important for us to view late life depression as an event that will change this person's life. It substantially increases the risk for decline. I've mentioned that it increases the risk of them being diagnosed with dementia in the next year or two, and that's hugely important. That treating depression for the first time over 65, that one keeps that fact in mind, that most or many will go on to develop dementia. The risk factors for late life depression, I've mentioned that being a woman is one of the major risk factors. Major life events such as being widowed or divorced. We've talked about the structural brain changes that are considered normal, but if they're accelerated, that's another risk factor. And the peripheral body changes that might lead to physical illnesses that cause functional decline are thought to be a risk factor as well. And the other one that we've already talked about is being a caregiver for a person with dementia or other debilitating medical condition is a huge risk factor for developing depression late in life. Mood disorders due to medical conditions we've touched on, and I'm not going to read this slide, but strokes, endocrine disorders, Parkinson's disease, sleep apnea, all huge risk factors for developing a mood disorder secondary to having that medical condition. Depressed elderly have twice the number of medical appointments compared to age-matched, non-depressed elderly patients. They have an increased number of medications taken, and I'm not talking about the antidepressant medication, just medications that have been added for the somatic complaints that these people might be more comfortable going to those twice as many medical appointments for. They do spend twice the length of time in hospital for other conditions. And in nursing homes, we know that depressed long-term care residents will increase nursing time in the long-term care homes. How might we improve recognition of late life depression? So for clinicians, I think it's not being kind of led down that path of, wow, she has so many problems medically and physically and emotionally, I'd be depressed too. Not to get stuck in the medical complaints only. So I always say to the medical students, if the patient can only talk about their bowels, and every question you ask leads back to their bowels, please be thinking about the possibility that this person might have a depression and simply be focused inordinately on a somatic symptom. In the medical profession, a fee-for-service payment strategy that many of us work under, and particularly in primary care, doesn't give people the time they might need to explore emotional needs. And we know there's problems in integrating the mental health and primary care systems. For patients, though, patients come with their own stigma about mental illness. And many, as we hear over and over again here, have to be dragged to an appointment at the Royal Ottawa. If they've grown up in Ottawa, simply having an appointment might point out to people that they're crazy, and so they don't want to come for an appointment. Luckily, most of them, once they come, are relieved that they really are meeting, I think, pretty nice people in a beautiful building, and it's not too scary. But that's the stigma that they bring and their caregivers can bring. Misinformation, and as I mentioned, more comfortable to report physical illness. Treatment and recovery, though, are possible for all, and it may not be complete remission of all of the symptoms that that person lives with their mental illness. But we have more and more practice guidelines that are focusing on mental disorders in the elderly to guide us as to how we might best treat people with mental illnesses. We've had many recent enhancements in training and education for physicians, and I know that I'm often asked to help with allied health professionals in bringing at least the geriatric psychiatrist perspective to their learning. And we have a new Royal College subspecialty in our field of geriatric psychiatry that I think is going to help us to have better treatments and to roll out better treatments. So medication, I've mentioned, can be an important part of treatment and recovery, but you have to keep an open mind and keep your eyes open about changes you might have to make in those medications. Psychotherapies can be an important part of treatment and recovery for all ages. You know, Freud said that you couldn't give psychotherapy to anyone over 40 because they were too, at that point they became too concrete and couldn't change. Thank God that isn't true anymore. And we have some good evidence that psychotherapies can work for people well into their 80s and 90s. ECT, which we won't talk about today, I just simply say is an important part of treatment and recovery for severe depression in the elderly. And of course, this audience knows all the good things that they need to do to stay well and be well and look after their brains, so I won't list those. So growing old with a mental illness is not for sissies. Early onset mental illness in patients who've grown old may require a fresh look at healthcare professionals who come into the sphere of that person. Late onset mental illnesses can be complex, but not impossible to tease apart. Prevention, early identification, treatment, and follow-up are the keys, and another whole lecture could be given about the system we have in place that really sometimes doesn't allow for the follow-up that might keep people well. And mental health services for the elderly, they can be fragmented. Some are lacking in availability, but I think improvements are happening every year that I'm in practice. So thank you very much, and I'm available for questions now. Dr. Azad.